Good evening, this is Dr. Nader Hamada. We will talk today about how to measure ABPIs, and on the following video we will do it practically to see how can we measure the ankle brachial pressure indices, which is a very important test to diagnose and to follow up patients with peripheral arterial disease. So from the term ankle brachial pressure indices, it means that we have to get the pressure around the ankle, we have to get the pressures around the brachial artery and divide the ankle over the brachial. So the first thing, how to get and where to get the brachial artery pressure. The pressure that we are talking about is the systolic arterial pressure. So there are different ways to get the brachial arterial pressure. There is a palpatory method when you inflate the sphygmomanometer around the cubital fossa and try to feel the radial artery, and once you start to feel it after occluding the artery, this is the systolic brachial pressure. There is a way to use the stethoscope to listen to the Berwi, but we cannot use these ways to measure the brachial pressure because we cannot apply the same method around the ankle. So to standardize the test, we have to use something that could be used on the brachial artery and around the ankle as well, which is the handheld Doppler. So what we will do, that we will actually feel the brachial pulse on both sides, and we will put the handheld Doppler on the right side first. We will inflate the sphygmomanometer above 200 millimeter mercury above the Doppler till the signals disappear. Then we'll start to deflate the sphygmomanometer till we get the first sound, which will be the brachial systolic pressure of the right side. And we'll repeat this again on the left side, and we will eliminate the lower value. The reason for that actually if the patient has 120 millimeter mercury on one side and 180 millimeter mercury on the other side, this means that the actual pressure of this patient is 180, because there are different diseases that can cause drop in the blood pressure in one arm, but there is not a lot of diseases that can cause one arm to have higher blood pressure value. So there is no relationship between the right upper limb and right lower limb circulation. So if you want to obtain the brachial pressure, you will get the two values and then you will take the higher one. What about the ankle pressure? Remember that we are doing this test for patients who don't have palpable pedal pulses. So we will apply the handheld Doppler over the anterior tibial artery first, and we will inflate the sphygmomanometer till the signals disappear, and then we'll deflate it, and then we will get the systolic pressure in the anterior tibial artery. Then we'll repeat the same thing in the posterior tibial artery. We know that the anterior tibial artery is in front of the ankle joint, midway between both malleoli, while the posterior tibial artery is just behind the medial malleolus. So we will get two values: systolic pressure of the anterior tibial artery, systolic pressure of the posterior tibial artery. At the level of the undergraduate, we will just get the higher value because theoretically one artery is enough to vascularize the whole foot. But in vascular surgery, sometimes we get two different values, which is the anterior tibial and posterior tibial, and then rather than getting the ankle brachial pressure index, we get the anterior tibial brachial pressure index and posterior tibial brachial pressure index to get the angiosome pressure. But at the level of the undergraduate, we will get the higher value, and then we will divide it by the higher value of brachial pressure, and then we will get a number. If this number is above 1.2, this means that this vessel is not compressible. Sometimes you can get an indefinite value. So as long as you are inflating the sphygmomanometer, you still can hear the Berwi or the signals with the Doppler, even if you reach the highest pressure on the sphygmomanometer. And this means that this vessel is very calcified. So while you are trying to exert the pressure to occlude the vessel, actually the most of the pressure that you are exerting is going against the calcified wall of the vessel. So you are not actually measuring the pressure of the blood inside the vessel, but you are trying to oppose the calcification in the vessel, which is common in patients with diabetes and end-stage kidney disease. So if the patient has 1.2 or more ABPI, so this is not compressible, and you cannot really rely on this value to decide if the patient has moderate or mild or severe disease. The normal value is between 0.9 and 1.2, and remember, this normal value doesn't mean the patient doesn't have peripheral vascular disease, but usually this patient will have a very mild degree of peripheral vascular disease that is not affecting the flow around the ankle, or the collateral flow actually is getting more blood delivered down at the ankle level. Between 0.7 to 0.9, it's a mild disease. Between 0.5 to 0.7, it's a moderate disease. From 0.3 to 0.5, it's severe disease. And if it's below 0.3, usually the patient would have critical threatened limb ischemia. But you have to remember that maybe the patient, you'll get a value of 0.7, and the patient has severe symptoms or gangrene, and maybe because the patient already have non-compressible or partially compressible vessels. So sometimes these values need to be correlated to the clinical symptoms and signs. One of the most important things about ABPIs is it's a very good, valuable prognostic factor. So if you have a patient who has a peripheral vascular disease and he will be treated conservatively, then you can follow him up by using the ABPI to see if it's getting better with treatment or not. Again, if you will do any intervention for peripheral vascular disease, you can assess the success of intervention by the improvement in ABPI following the intervention. Some patients might have claudication, but when you try to feel the pulses, you feel some weak pulses at the pedal level, and the ABPIs are normal. In these cases, it's advised that actually this patient will do an exercise ABPIs. So this patient will start to walk on a treadmill and then revisit and remeasure the ankle pressure to see if it's actually getting higher or getting lower. If it starts to drop with exercise, so this patient actually has a peripheral vascular disease, even if the resting ABPI is within normal. In the patients who have non-compressible vessels, how could you assess their circulation? There are different other methods. The most popular one is to measure the toe pressure, which are less liable for calcification, but unfortunately the toe pressure couldn't be measured using the handheld Doppler, which could be found in any vascular department. It has to be measured by laser or plethysmography. Thank you very much, and in the next video we will discuss how to do ABPIs on a patient.